So it looks like we're all set up now. Thank you everyone for joining us here at Global Giving and online if anyone's joining our Google Plus Hangout. Today we have Dr. Raj Panjabi. He is the co-founder and chief executive officer of Last Mile Health. I made some notes because Last Mile Health and Raj has done some amazing things before we get started. So basically, Last Mile Health is a Liberian-based, community-based organization. It's been involved in the fight against Ebola since the first cases launched in March 2014. And Raj will explain a little bit more about what Last Mile Health does. However, their project on global giving recruits and trains clinical workers, clinical mentors in the field and in the most rural parts of southeastern Liberia, correct? And Raj, at age 9, he escaped the civil war in Liberia, am I correct? And then later came back to co-found Last Mile Health. And some other interesting notes, in addition to being co-founder and CEO, he's also the associate physician in the Division of Global Health Equity at Harvard Medical School. He is a Draper Richards Kaplan Foundation Social Entrepreneur, an Echoing Green Fellow, a recipient of the Global Citizen Movement Award, an advisor at the Clinton Global Initiative, and he was featured as one of Fortune's World's Greatest Leaders. So this is amazing. Thank you so much for joining us. Raj will present on Last Mile Health, and then we'll open it up for Q&A. For anyone that's online, if you have any questions or comments, you can go on Twitter and do hashtag Ebola chat, and I'll be following that over here to the side. So I'll hand it over to Raj. Yeah, thank you.
Collision of hashtags and Ebola. It's a only place. Well, thank you for having us, and we've been so excited, to work with you when bad things happen. As I know personally, just from having been in the war and having fled it. Your real partners by who you can count on at your moments of greatest need. And we've been able to count on you in everything you do every day when we've needed to count on someone the most. So I just want to express my thanks on behalf of the team. Alicia McCormick on our team is here as well, and I hope she'll take part a bit in the back and forth we might have. How many people here? I just would love to hear a little bit from the group from Dickinson College and the group of interns that are here. Why did you come to Global Giving? Why are you in this fight?
I guess for me, I knew I wanted to do social impact and I wanted to do something with social justice, learn more about it. And when I had my interview here, I was so taken aback by how comfortable I felt from the very start and how motivated and inspiring everybody was the very first time that I spoke with them. And then when I researched more, I just never heard of anything like Global Giving, and I really appreciated the values and be always open and never settle, and just the story of how it all came about, that I felt like it was something that's going to be huge and I wanted to be part of it.
Inspiring community of people who definitely follow the values that they started with and founded the organization with in the first place. You can definitely see, like, even in the little meetings or the little chats between people, how much everyone is really dedicated to actually bringing those visions to life. And being a part of that day to day has been really awesome.
For me, I've always struggled with the model of global aid and development. Took a course in my sophomore year that really discussed all the issues with the current models of, just sending resources and money and kind of encouraging someone else's programs as opposed to having the community members start it themselves. So actually hearing of an organization that did that, and then I'd never run across it, and I kept looking for it, and then they kind of found me. I was like, wow, that worked out nicely. So it's nice to work for a place that I actually believe in and that matches my model as well.
Wow, I'm just gonna quit. I think they didn't have these guys talk. That's really inspiring. Thank you for sharing that. I have to say, a lot of what you just spoke about, the three of you, about inspiration, about working on what you believe in, and working with actors that are local and community based. A lot of that is what drives the way we think at Last Mile Health. I some of you, I just talked with a few of you, work with my friends Britt, who I went to college with, and we worked on some of the same things back then. We never got the privilege of being an intern at a place like this, which is awesome that there's an opportunity like that now. We're going to talk about that, about being relentless about what you believe in and focusing on that. And I think we've learned that it's mattered more during a crisis than it did even before it, and it might matter even more after it in all the shakeup that's happened from it. So how many Ebola groups have you worked? How many groups working on Ebola did you work with during this?
Yeah, we have about 27
Great.
projects and organizations.
Fantastic. Just on Ebola in West Africa. Terrific. Outstanding. And I bet we've worked with a lot of them as well. I want to start off, because you guys got very personal. I'm going to get personal. This is Mari and I were at a Facebook summit in Menlo Park in January to speak about social good. And they had asked us to speak about what Facebook's role could be in social good. And so I got inspired to go back into my Facebook feed and found a very embarrassing picture of when I was 9 years old and a fourth grader in a school in Monrovia, the capital of Liberia. This was our yearbook picture back then, and some amazing folks in the picture. The guy in the corner with the curly hair, Christian, he taught me how to swim. The guy who looks like with the Where's Waldo type of shirt, and I can pick on him. He's been a lifelong friend of mine. And a number of these people, just like any of us, made up my life back then. And then all of a sudden, this became the last photo that I ever saw of that group. And within weeks of this photo, a civil war had come to our doorsteps in Monrovia. It had started in the countryside in Christmas of 1989. And how many here have heard of Charles Taylor? So Charles Taylor is the rebel leader at the time and ended up becoming president of Liberia. Now has been indicted and jailed by the International Criminal Court for crimes against humanity. He led a force of about 300 and then growing rebels that entered our town, pillaged the countryside, and within a few weeks, these were the kinds of images that many of us saw. Of children holding guns, of lives being lost, of, in my family's case, my dad's retail goods store selling buckets and candles was looted. My mom, sister, dad were huddled together like many of our relatives and friends, trying to make decisions about how we would get out. And they had shot down the major airport. We were, one morning, my mom said, pack your things, we're gonna go. And as a 9-year-old, things are wrong at that time. Something's wrong, but you don't know what's wrong and why it's wrong. But there were moments when we were being evacuated, like when we were stuck into two lines on an airfield in the middle of town, split, mom, sister, and I in one line, hundreds of people with a different skin color, with a different passport, who tried to jump in a cargo plane that we were shoved into, that were not allowed to come on that plane. Those moments stuck with me. We got to escape, they didn't. And I imagine for many of you in this room, again, there are moments that question your belief system, that question what you stand for. And sometimes they're not the most obvious moments. Sometimes they're moments you reflect back on. And I reflected back on that moment when I was about, what year are you all in now? Juniors, yeah. So I was around my sophomore, junior year, reflecting a lot on those times and trying to understand why. And it came down to this very basic thing, that line represented something, being split, that people could have such different fates, even though they are the same human beings, that inequality was deeply destructive in this world. And I had just become a medical student. I was 24 years old, and all of a sudden the war in Liberia stopped. Charles Taylor was removed. Liberia elected Africa's first female president, who ended up winning the Nobel Peace Prize, Ellen Johnson Sirleaf, and it set up this revival. And I had been reflecting on that moment in the line, what it meant for healthcare, learning about global health inequality. And so I wanted, like many of you probably would have wanted to, is to go back and find out if you could take part in rebuilding something that was better than what caused the problem in the first place. And so I went back home after living in North Carolina with a family that helped us get back on our feet. And I was a medical student at UNC, and I was 24 years old. I went back in, a lot of enthusiasm, a lot of pizzazz, a lot of belief, and then finding this in our country. War had caused 15 years of conflict. We'd lost 250,000 of our people. The kind of destruction you'd expect to see after a war was there. Copper wires pulled from the electrical lines. Even the Capitol didn't have electricity. Capitol didn't have running water. The one major water dam had been destroyed during the conflict. You had clinics and hospitals and school buildings destroyed. But the worst type of destruction was the lack of human capacity, people. We had just 51 doctors left to serve a country of 4 million people. And to put that in perspective, that would be like San Francisco having 8 doctors, or Manhattan having just under 20 doctors for an entire area. So you can imagine, you try to live up to what you believe is in, or at least what you believe you should fight, inequality, and you run into all sorts of challenges. If you were around the few doctors that remained in the city, you might stand a chance when you fell sick. But for those that we were serving in remote villages of the rainforest, which became incredibly important, as you now know, in the last 15 months with Ebola, you'd often die anonymously, dying from things that people really shouldn't die from in the 21st century. Dying from childbirth, dying from basic infections of the lung, pneumonia. Just because people live days away from the nearest clinic, you'd have to walk to get there. Antibiotics could have saved you if you were closer, if the care was given closer to home. And instead, patients come really sick, 7-day-olds that I held in my arms, that I put my stethoscope on, whose lungs sound like choking car engines 7 days after they're born, that don't make it because they didn't get antibiotics fast enough in their homes, that mom had to walk 8 hours to get to the clinic. That's the life in these places, and that's what we were seeing in remote villages. And it turned out, that understanding how people lived in these places really mattered. So we spent a lot of time taking illness narratives, listening to people, going to their homes, doing home visits. And here's what we found. If you were a 2-year-old, if you were a mom or a brother or sister of a young 2-year-old, and that 2-year-old fell sick with a fever, you'd have to hoist that 2-year-old on your back, get to the river, get in a canoe, paddle across, get to the other side, and then you'd have to walk for up to 2 days just to get a diagnosis. A lot of people look at this, and no one in this room would challenge this assertion. Some people say, why should we care about people that are all the way on the other side of the planet, that live in these really remote areas and nothing like us? No one here would say that because you signed up for global giving. But it turns out that their lives are connected to ours in more ways than we thought. In 15 months ago, in December of 2013, another little boy who was 2 years old would come down with fever, vomiting, and diarrhea. He would die of a mysterious illness in a rainforest village across the border from us in southern Guinea. Same rainforest, different country. Village of maybe a couple hundred people. Small place, hours away from any near real healthcare, a clinic. He dies, mom dies a few weeks later. She dies, grandma dies a few weeks later. She dies, sisters die a few weeks later. Other people in the village fall. Other people in nearby villages fall. That's right on the border with 2 other countries, Sierra Leone and Liberia. Many people in those countries start to fall of a mysterious illness. It's not until 3 months later, in March 2014, when people realized that this is Ebola. By then, it spread to several villages in the most remote corners of 3 countries, in the same kinds of villages we've been supporting. And it would eventually go to capital cities. It would go to several countries. It would cause bowling alleys to close in New York. It would cause schools to close where you're from in Dallas. Political careers would be impacted. Billions of dollars would end up being lost, and still counting, in economic loss. Contractors would close their doors. Mining companies would lose their contractors. Jobs would be lost. And then somebody said aid reform. Billions of dollars of aid would be spent just to catch up with this epidemic. One boy, fever in a rainforest, in a place where there was no health care. It turns out that this is not simply a challenge of one part of the planet. Ebola is just a symptom of something much more deeper. It's a symptom of the fact that there's 1 billion people on this planet who live like that little boy in places that are all too far, what we call last mile villages, too far from the nearest clinic. They live in hard to reach areas. The public sector thinks these places are too hard to reach. The private sector, there's not enough consumers in one place to make a market. And the nonprofit sector thinks it's too expensive to serve them. It costs too much per capita to go out to remote villages of 50 to 150 people. So we chase big numbers of people and we leave the smaller villages behind. And these are the consequences. When we have that, it's Ebola and the spread of it. What if that could change? What if threats like Ebola anywhere are threats to people everywhere? Shouldn't part of the answer be getting healthcare to work for anyone, anywhere? Getting healthcare to work for anyone, anywhere. That was essentially the premise on which we started Last Mile Health. How many here have heard about or worked with community health workers? Great. So for those who may not have, the idea is simple. You take where it's hard to build clinics, or clinics haven't been built, or even if they have been built there, how do you provide healthcare? So this idea of a community health worker, you take a woman like Zakba, who's in a remote village called Bilabo, way out in the remote rainforest, 2 days walk from the nearest clinic. And she's had a 7th grade education, never had a job before. Some program comes in and says, we want to provide healthcare here. You should sign up to be a health worker. Village chief nominates Zakba. She goes off for training. She gets a couple of days of training on some disease. She goes back in their community. She's not equipped. She's not paid. She's not supervised. We treat people like her like an amateur, and we expect her to perform miracles, provide healthcare where it's never been provided before. And it just doesn't work. That's what we found. In the villages we work in, there's 1 out of 33 of community health workers actually existing that are on paper. If you look at the workforce of community health workers around the world, so many of them are undervalued that they underperform and they don't actually provide care in the way that's possible. And so we thought to ourselves at Last Mile Health, what if we could actually change that? What if we actually create a new workforce to save lives in the world's most remote villages? What if we could give people like Zakba the training, the equipment, the supervision, the coaching, the employment that they need to save lives? What if we could take them from working and being supported like amateurs and actually converted them to professionals? What if we could professionalize village health workers? And what if we could do that in a way that was actually replicable? We could take how you recruit, train, equip, manage, pay a worker, make each step more efficient, more effective. Could you do something better? Of course, this particular guy who spent 7-8 years in medical school and a lot of lost hair during that time, who thought medicine would be the answer alone to everything, realized that actually a lot of the thinking around business, how you make things more efficient, how you execute something, it shouldn't just be the purview of business to do that. Global health should do the same. Any of us should do the same. But that's what really mattered as much or even more than medicine alone. I did not go back to go get an MBA. We ended up having a great team that helped us take this idea and apply it to someone like Zakba. So what if you could professionalize it? What if you could do it differently? What if you, instead of having the village chief recruiter, you could actually run? How many of you get recruited by a village chief to go to, where do you want to go to grad school? What do you want to do?
To be honest, I'd like to go back into the field first. I've lived in Rwanda, Mexico, and India.
Yeah.
And I thought I knew what I wanted to do, and then I went into the field and did that. I
Did you take a standardized test to go to college?
SATs, ACTs.
Yeah. if the college said, I'd like to pick you to go train in something, and I want your neighbor to choose you, would you have done that?
Repeat the question.
You don't get chosen by your neighbor to go to college, do you? Right. You got to prove yourself. And so we said, what if you recruit a worker like Zakba by giving a literacy test, by actually putting her on a probationary period before she got signed into a contract? What if you actually gave her training, not just for a disease for a couple of days, but actually mapped out what was killing people in her community and trained her in the top 10 things, everything from prevention to diagnosis to treatment to care and follow-up? What if she could be coached instead of just sent back in her community without any health care? Give her a nurse that it's the coolest nurse job in the world. You get on a motorbike 50 miles a week, you go out, you spend time with a person like Zakba, and you teach her how to diagnose a kid with malaria. And then when you make sure she's doing it safely and effectively, give her a backpack full of equipment that never runs out, that can test kids for malaria or help you with screening tools that could screen kids for Ebola, or gowns that can protect her in case Ebola does come up in her community. What if you could do all that and give her a contract and tie it to her performance? She hits a certain number of kids immunized. In other words, she hits targets for immunization, not hitting kids for immunization targets, and actually getting mothers care for pregnancy, screening people for Ebola. What if you could do all that? Could you convert someone like her into something that can add a lot of value and actually care for people? Here's what happened. She's able to screen her community for malnutrition, care for kids with fever. She's able to work with her colleagues to provide prenatal care in those communities. She did all this in a place called Konobo. This is before Ebola, but in the same rainforest Ebola came to. In a place like Konobo, the places she worked in, these so-called last mile villages, remote areas, the average age of death in Konobo when we started, before Zakba started, was 28.6 years. It actually has some historical relevance. Turns out that that's about the age of death in another part of history, in another part of the world, in Europe, but not now, actually 500 years ago, during medieval Europe, during the plague. That was the average age of death. This is the 21st century, and people still live in Zakba's villages in that way. Why can't we get them health care? Zakba and her other army of frontline health workers, professionalized village health workers, covered the entire area of Konobo, an area the size of Rhode Island, and helped take immunization rates and prenatal care rates dramatically up, got care for mothers and children, in other words. And that all happened right before Ebola. They had provided primary care in this area to people who had never had it before, care in remote villages. Those same workers were critical during this crisis. How many remember, how many's ever seen this curve before? In September, the CDC director, Tom Frieden, had come back from Liberia and from West Africa and said that if we do nothing more, the 27 organizations you've helped support, if they hadn't done more, if you hadn't stood behind them, by January of this past, a few months ago, in 4 months, we would be seeing 20,000 deaths a week in Christmas. That's how many. I've not seen those numbers projected during our war. So you can imagine for many of us what that felt like. And I know what it felt like for you, which is why you took action. It's because of action like yours. People in this room who talk with partners and supporters, when you send emails, blasts out to get people engaged, when you promote the work of your projects, especially at the community level, here's what can actually happen, right? Here's what happened with us, with you guys behind it. In Riverside County, this is Konobo, this is in the southeast, Monrovia is here, the capital, 17 hours to get here, 10 hours to get to this. In Riverside County, Lorenzo Dorr, in a place called Kaya, a remote area 10 hours away from Monrovia, a woman with Ebola got diagnosed in Monrovia. She was afraid, like many of us would be when you have a deadly disease, wanted to be close to, who would you want to be close to? Your family. Went into the rainforest where her family was, a place called Kaya, 10 hours from the capital. There's no cell phone access. There's no roads. The community had heard about Ebola. This is in October of 2014. They didn't know about modern safe burials. And you know this disease transmitted primarily during burials and when people were very sick. They buried her when she died. 14 days later, Lorenzo gets a phone call along with the Ministry of Health in that region. This is one of the frontline health workers on our team. In fact, he leads frontline health workers. Gets a phone call 14 days later after this woman dies that 14 people had died in that village. They're 10 hours away, and here's the kind of stuff they had to do to get there. They get into jeeps, get into the rainforest, find where people were sick, get their blood samples, get them into care quickly in treatment units, even if they were very far away. Make sure that door to door, those who were at risk of falling sick, those are the so-called contacts of patients, that those were actually cared for and followed over 21 days. If they fell sick, get them into care very quickly and educate and prevent the disease from being transmitted from one place to another. In other words, hunt down the virus and stop it in its tracks. He did that along with many other people in that response, educating, the surveillance, the contact tracing, the gowning, the donning, and the doffing of the spacesuits, as you've seen. And here's the results. 1,300 workers, community members, village chiefs, healers were trained. 33 primary healthcare facilities, the remote clinics, even if they're very far away from these villages. When you refer a patient into a clinic, you can't have a midwife or a nurse there who doesn't know how to care for a patient. You can't have them not have a thermometer. You can't have them not have a proper place to sort out whether a patient has malaria or Ebola. We provided 22 tons of support to them along with the government of Liberia, and 2 counties were supported. A lot of people they eventually reached survived that crisis. If Ebola anywhere is a threat to people everywhere, as I said before, part of the answer has to be getting a health worker for anyone anywhere. And it turns out that this was critical not just for stopping Ebola, but also critical for keeping kids alive. Where ZACPA was, and this is how some of your support helped, they kept 6,000 kids on treatment for malaria, pneumonia, other causes of fever throughout this crisis. Why is that significant? Because across the rest of the country, people had virtually stopped providing healthcare. Kids with malaria stopped coming to the hospital I trained at in Liberia. We had 0 patients in the pediatric ward. That's not because no one was sick. It's because people were running away from healthcare rather than running towards it because they're afraid they'd get Ebola. And community health workers in Sierra Leone, 3,000 of them we heard in one botch stopped working because they said if a health worker goes out and they get Ebola and they die, that's a very bad thing. It's dangerous for them. And they're right if it's not done the safe way. In our setting, because we've been professionalizing these workers, the nurse coaches of people like ZACPA said, what if we developed a policy that said we could treat patients at a distance? We'll just talk by the history of the mother. We'll ask them if they have a fever and we'll treat accordingly, rather than stopping services altogether. You might treat more kids that don't have disease because the mother got the temperature wrong, but you'll save a lot of kids that would have otherwise died. And that's why 6,000 kids, 7,000 kids did not miss a single treatment dose during this crisis. For mothers, this is the rate, the drop in facility-based delivery, safe deliveries across the country. This is the ripple impact of Ebola, the non-Ebola causes of death. 3-fold drop in mothers getting access to safe deliveries. In Konobo, it dropped 3%. So this is the power of you getting a health worker for anyone, anywhere, is that you can stop a crisis, you can be resilient during a crisis, you can get to 0 cases. We're there now. If we stay there for 2 more weeks, we might be declared Ebola free. And yet there's so much more work to be done if we don't want this to happen. Again, the crisis is not over because the crisis in remote villages still matters. People across Liberia do not have access to healthcare. There's still 1.5 million people who don't have access to a professionalized community health worker. They don't have access to primary care. Ebola, how many think that Ebola started and was introduced to this region just in the past year? How many have heard that story in the media? Some of you have heard it, right? That this was new to West Africa. It's not new. A few of our colleagues and friends, along with the government, found that there was an obscure German medical literature in 1979. Study done, 1,600 people were followed for their blood levels. Turns out 6% of them had Ebola. They weren't looking for Ebola, so the paper wasn't about Ebola. They had 2 lines in the discussion section that said, Ebola was found in this study, 1982 medical journal. Somebody should notify the authorities that people should be trained and provide healthcare in this place. This thing has existed. We've been lucky. So if we want to stop this, we have to, and keep it from coming back again, in the recovery, we have to be committed to getting to a health worker, anyone, anywhere. President Sirleaf has committed to this vision to train thousands of these workers. There's a plan to do it. There's 4,000 projected workers over the next 7 years. If the financing can come through for it, there are a bunch of groups looking at that. And the goal would be to populate every single corner of this country with one of these health workers. And that's a very exciting vision. A health worker for anyone, anywhere, not because it just matters for Liberia, but I would argue it matters right now for the world in a way that it never has before. And that's something that we're really excited about continuing to work with you all on. So I'm going to stop there and take questions.
Oh, and some questions haven't come in yet, but I have a question. Have you found that this model could be replicated in other countries that are facing similar healthcare infrastructure issues, but might not have maybe epidemics similar to Ebola?
I think it's a great question, and we know the answer is yes. I think that a good example of where something like this has been replicated is Ethiopia, where there are several thousand of these workers there. That country made a commitment to do this a long time ago. They have seen a big drop in their maternal mortality and child mortality rates. I bet if they were hit with Ebola or anything like it, this is the workforce that would be mobilized as part of that response. Nigeria, while I did something different, though they focused it on polio, those same polio workers were reappropriated as Ebola workers when Ebola came on a plane to Lagos in August of this past year. And I heard there were some 19,000 or more home visits done by those workers to help stamp this out. They minimized their epidemic and stopped it within a few weeks. So it's very powerful what can be done. It is needed. The financing is something that is their groups, their financing needed at 2 levels. One is you need the financing once an innovation is there to go to scale. That might be the World Bank, it might be the governments themselves. There's also a lot of financing needed just to produce the innovation in the first place. So not a lot of countries, those are exceptions, the ones I gave. There are very few that have professionalized these village health workers. And I think there's a lot of need for community-based organizations who I think want these workers to be supported better, to have the resources to make a difference and actually prove that that can work.
Yeah, and I'd love to ask a follow-up question.
Yeah,
about
can
that.
I hear your names? I'd love to hear.
Sure. So my name is Alexis Newton. I'm a program manager here at
Okay.
Longterm.
Alexis?
Yes.
Great.
And I think you correctly guessed that a lot of our partners do have the community health worker model. That's something we've seen in the field a lot, and it is primarily on a voluntary basis. And so I'd love to hear what the payment model looks like, and even in terms of numbers, I'd love to get
Yeah.
a sense of what the income for a community healthcare worker would look like.
Yeah.
In this model, and I'd also love to better understand the, I guess, what the structure, the organizational structure looks like. So who the community health workers are reporting to and who they are reporting to,
Yeah.
what that structure looks like for you guys
Sure.
right now.
That's something, you want me to take that?
I'm happy to speak to it. Whatever
Sure.
you prefer.
Why don't you? Yeah.
Yeah. So, hey guys. My name is Lisa McCormick. I work with Raj on the exec team of Optimal Health, and have been back and forth. Hi, speaker. Back and forth a lot between Liberia and over the past month. So, great question. There's actually been a lot of work that's kind of looking at different models, the different components that are needed for effective community-based delivery of care. And in terms of a lot of the work that we've done with the recognition that we actually need in very remote geographies, a higher level of performance from community health workers based upon the fact that quite frequently there are really significant barriers to referral. So the need, as Raj spoke about, to actually professionalize them and not necessarily have them just do health promotion or referral, but also to be able to do appropriate diagnostic and also treatment, so interventive active actions for disease, actually requires that it is something that is more professionalized and is actually tied to a performance-based contract. So in terms of the payment, we actually pay our health workers on contract $80 a month. It is something that has, I think a little bit of what we're looking at in terms of also cost sustainment and feasibility. Some of this is actually attached to a paradigm shift, right? So if we're looking at things through a health equity lens, and you're actually looking at what a lot of countries are spending on health services in Liberia pre-Ebola, they were actually spending per person $52 per person. The services that we've been able to render through community health worker on average somewhere around $6 per person. But when you look at a district like Konobo, there was a very inequitable distribution of actual spending for health resources. So in Konobo, even though it was an average of $52 per person nationally, it was actually 71 cents in Konobo. And a lot of that was attached to the fact that even if the government had wanted to invest more heavily in some of these areas, there actually wasn't a mechanism that was capable of effectively getting health services out to the just general populace who really needed it. So does that answer your first question in terms of contracting and payment? Yes, it does. Okay. So then in terms of the actual supervision structure, a lot of the work that we're doing and fundamentally what we're driving towards, we've been working very closely with the government all along in the Ministry of Health, as well as what is sort of the functional operating unit in Liberia. So while you have a central ministry, the unit of operation is actually at the county level, and then you have districts that lie underneath that. So a lot of what we have been moving towards is actually support of both the ministry at a central level to be able to fashion and manage this type of this program, as well as funnel resources effectively for the operating units of the counties to actually be able to deploy these activities at a field-based level. So the community health workers are actually overseen by a nurse supervisor. So it actually is somebody who has clinical capacity and clinical training that's actually going to continue to monitor them and to support them, and to make sure that they're actually professionalizing on the job. And that person is responsible for their skills evaluation, is doing regular supply audits, is also doing audits with members of the community to make sure that the services that are supposed to be rendered are being rendered and that the things are working well. And then that nurse mentor is actually embedded in the primary health facility. It would be the referral unit for things that would be a higher level of severity where folks would have to get referred in. And then that primary health facility falls under the county health team. So really what is being designed is something that's an official extension of the public health system, as opposed to something that's sort of just an add-on or segregated. Does that answer your second question?
Yeah, that's great.
Okay. Do you have anything to add?
No, thanks.
Sure.
Anyone else have any questions?
Yeah. What's your name?
Camilla,
Camille.
I'm in the public services team,
Great.
one of the agents. And my question was, this kind of issue like Ebola or even the earthquake in Haiti, they draw a lot of attention, a lot of funding for the country in that specific moment, which is obviously great because you really need it. But in the long term effects of this kind of crisis, how is not only the country but organizations like yours facing this, like the consequences of this problem right now?
How are we facing the
How are you planning to face this in the long term?
in the long term? Yeah, that's a great question. We're counting on you. I'm kidding. We are counting on you. It's true, but no, I mean that. I think there's a lot of groups. This is why you have a focus. How many of the 27 you worked with? How many were community-based, local-driven type of groups?
That's a good question. I would say about 40%.
Great. So that's answer number one, is that supporting and investing in local organizations, the ones that are deeply committed and don't have an exit strategy. We don't have one. Is really critical. The second is actually working to leverage and sustain this, right? I mean, healthcare is a human right, and governments are mandated, and often, like the Liberian government, are actually want to provide healthcare to all their people. So we work really closely with government to help them shape their policy based on this. The whole pilot in Konobo was designed as much by us as it was them. I mean, they're the ones who defined the problems that we needed to focus on. How do you pay these workers? Who coaches them? What their supply chain looks like. That came from the Minister of Health of Liberia. And we asked, what are the policy problems you're facing? So there's got to be that level of sincerity, right? We essentially took marching orders from them. We didn't just partner with them. We took marching orders from them. During this crisis, we seconded staff to them, which was really important, right? A lot of people look at ministries of health and say, you don't have the capacity, we're going to do it ourselves. And we were saying, well, some work needs to be done by others. That certainly is true. But what work can be done by ministry and government, let's help them to do that. So those are essential principles as we try to help them scale this program, right? The next 7 years, they could have 4,000 workers. They can't do it alone. They're going to need help, but they should be trying to push it forward. And so we're going to second staff to their central Ministry of Health to help them take this at a national level, organize other partners. We're not the only partner working in community health. I hope not. Otherwise, what have we done? If we haven't inspired others to engage or helped others engage if they're already inspired to do it. The second thing is at the field level. How can you coach and support and the local county Ministry of Health teams? Because the national governments change maybe every 5 years or every 10 years. The local governments and those people don't change as frequently, and that helps sustain it as well. So idea is policy, do the project, demonstrate it, help them plan to incorporate it nationally, and then help them deploy it. But ultimately, they're the ones leading the program and sustaining it over the long term, which only takes a few minutes to get done. I'm kidding. Obviously, it's a lot of work for a lot of years, which is why the local investment over time in a dependable way, like the kind of financing that you guys produce and support and encourage people to continue to support through global giving or otherwise, is really important.
I would, if I could, just add to that the fact that in this moment, it's really an opportune moment in which there's actually been a number of systems structured within the health arena and otherwise, as well as a number of health workers and health promoters, right? So we've actually trained 1,300 health workers in part due to the support that global giving has actually provided. Opportunity to actually leverage that human capital as something that can actually be used both for sustained community surveillance, because as Raj recognized, not only are there still infections in Sierra Leone and Guinea and risks across border migration, but also the reality that there might be some endemic presence of Ebola there. So I think some of it being a recognition of being able to monitor and have health workers for standard screening, but also for basic provision of health services, and how we're able to kind of utilize some of the infrastructure and training that's already taken place to make sure that some of the infusion of capital that's come through for disaster response is actually turned towards what we would stand behind as sort of the broader development goals.
Yeah, that initial investment you all made and the second one that you're looking at now, it's some of those 1,300 workers, in fact, a good 350 of them we're trying to pull into this deeper quality model like we already had in Konobo that kept all those kids alive, that also kept all those mothers in care and stopped the disease from being spread. And that we want to happen throughout the country. Yeah.
So I haven't worked in public health extensively, but I worked in Butari in Rwanda with Progress in Health.
Yeah, great.
And they have a lot of kind of community outreach workers.
Yeah.
And it
What's
was
your name?
Elizabeth.
Elizabeth, great.
Feedback labs.
Great.
Going into the community is something that a lot of people who were working at Progress in Health weren't able to do, and it just added an amazing addition to like kind of the programs. But there was a lot of backlash seen. Traditional medicine and systems that have been there for so long.
Yeah.
That do with taboo, voodoo, kind of more medicinal medicine. That's resistance that we saw.
Yeah.
That was really hard to make through. Like I know in West Africa, it's a lot more ingrained in society. So I was wondering if you guys have experienced any backlash with that, and
It's a really fair question, and we work closely with PIH in Liberia now. In fact, that they had helped staff some of the Ebola treatment units that these patients went to. I do think there's resistance, the major resistance is the resistance to not having access to quality care. And I think that's even resistance amongst the traditional midwives. You know, in our case, we worked a lot with those midwives. You look at the numbers for, you know, about 80% of mothers are getting access to care. I said safe deliveries, I meant facility based deliveries. A lot of those deliveries before we started were happening by midwives in the villages we work in. And of course, that was really important. They were providing, if that wasn't there, there would be absolutely nothing for people all these years. And so when we started, one of the things we did was call all the traditional healers together and their chiefs, about 53 of them, and said, how, you know, what are your pressure points? What are the challenges? And, you know, if we were to introduce care that complements what you do or strengthens it, is that a vision of yours? They said yes. And the second thing was also, well, what are then the incentives that obviously they're getting chickens, right? That was a big thing. They were, as compensation, they wouldn't necessarily get cash, they'd get chickens, but that chicken was valuable both as a symbol, but also valuable because it was food. And so we actually set up a system where the frontline health worker, like Zakba, when there is a birth to happen and a birth plan is created and a plan is created to go to the clinic, that traditional midwife is involved in making that plan. If there's a birth that has to an emergency basis happen in the village, and that does happen, the birth kits that are used, the traditional midwife is involved. And the last thing we do is actually pay each of them $3 for every delivery. We give them $3 for every delivery they refer in, and that it respects the fact that they're offsetting some compensation that they have. And that's been one way to engage them. So it's true, there is resistance, but again, often the resistance in places where you know, voodoo or other sort of informal ways of providing care are there. It's often political and economic, right? And certainly Partners in Health and others have shown that. I think many have in this world, that it's about poverty, but it takes a while to get there. Yeah. Does that resonate with some of your experience in Rwanda?
Yeah, it was difficult because I actually did exit interviews with kind of clients that we reached out to in the community.
Yeah.
And it was difficult because there was one midwife who actually came to us and said, what you guys are doing is great, you're saving people, but where does that leave me?
Right.
So I was just curious if you're facing similar.
Some of those have actually become our next line of employees. Like they've become the frontline health workers in some cases. Sometimes they don't. The hardest cases are where they don't meet the requirement of, say, a professional worker being literate, for instance, especially for women in a place where women have been excluded from girls' education. You know, it's a big challenge. I think the onus is on us, actually, to try to double down and figure out how to solve that. Not on them. You know, it's not their burden. Does burden have to be the last thing we say?
I have another.
Yeah, we have time for one more question.
Well, also, if there's anything on Twitter, I don't want to steal it, but well, this is actually amazing timing.
Ebola is the most favorite hashtag in the world, I promise.
This is kind of, I mean, you've done an amazing job building a case for your work and also talking about how you perceived the problem and how you've addressed the problem. And so right now, our team is working on developing something called the Social Impact Academy, and we're trying to think about how we can help our partners think about their social impact. And so, as a partner of ours, I'd love to hear if you were approaching that academy, what you might want to learn from global giving, or what you might want to learn from your peers about social impact. But I'd also love to hear how you guys think about social impact and how you measure what you do to see if it works. And a lot of, I mean, there's so many different approaches. There's a lot of debate out there right now on how to go about it. So I'd love to hear just how you think about that particular topic.
Well, that's exciting that you all are putting that together. Is it already something that's launched, or is it you guys are?
So we're putting the agenda together right now. It's going to be a 2-month online course, and it'll take place in June and July.
Great. You know, one just resource that we can just connect with, if you haven't already been in touch with the Siegel Family Foundation, Andy Bryant there and his team I bet you guys share a number of partners. They're very interested in how do you help grassroots and community-based groups go understand. I don't even think it's conversion's not even the right word, because why wouldn't you be grassroots community based and be about social impact? Isn't that where it matters most, at that level? And that's kind of the vision that I hear you articulating. They're excited about that. I think just first of all, sharing ideas there could be really valuable. What would we like to learn? I think it's a hard question, Leisha. I'm just kidding. I think it isn't that different than what you asked. I mean, how do you conceptualize social impact? And I, I think one of the biggest struggles, because if you asked us what our mission statement was 5 years ago, I would have told you it's advancing healthcare and the fundamental rights of the poor. Now, what does that mean for your mission? Does that give you direction? It means you do everything under the sun, is what it means, right? And there's nothing wrong with that being your value, getting healthcare for all people, for instance. But I think understanding how people in how do they preserve going the true rootedness. We're founded by community health workers in Liberia, like people who come back from the war. How do you that do care deeply about the people they serve? It's about who, not just about the what. When you hear a mission, advance healthcare and the fundamental rights of the poor, there's not a whole lot of what in there, right? It's just about who they're serving. How do you maintain that, preserve that, which makes you, not just because it's a touchy-feely, nice, fuzzy thing to think about, actually makes you more effective, and still add the sort of tools, the wizardry of social impact that's out there. I think to make that vision actually come to life, that to me is a very fascinating transition. And I think it's one I imagine a lot of your partners will be faced with. It's not either or, this is a continuum. And I think learning to coach and support people through that would be important. In terms of how we think about social impact, I mean, frankly, it's the only thing we're ideological about. I mean, I think for us, I will say that we do think, I think this is fair, Alicia, that the one, this isn't a critique about ideology in social impact world, but it's just simply evidence in the field. How is it that you have 1 billion people on the planet who live in 50 to 250 person, 350 person villages? And we still talk about the rhetoric, who don't have access to healthcare. It's the same 15% of the planet that have no access to mobile phones. It's the same 15% of the planet that have the least access to education and literacy. How is it that we in the global community are so focused on what? Is it HIV? Is it TB? Is it Ebola? Is it community health workers? Is it clinics? And we're so unconscious or not as conscious as we need to be about where that's being delivered. If we were more conscious about where we delivered care, if our true goal was inclusion, all people, we would care just as much about those 15%, even if it meant you're not going to hit scale targets, right? The impact metrics you might use here are ones that we were often coached on when we were working on this. Number of people served is your best impact indicator for scale. Think about what that means for the 1 billion people. There's 1 billion people on the planet. That's a lot of people. You reach 1 billion people that you have an impact. Those 1 billion people are spread across millions of square miles. The cost of doing care for them is higher than it might be for the other person who's an equal number in that stat of number of people served that might live in a city or even a rural area. You're always going to be biased towards serving those people most. And if your true vision's rights or even just inclusion, you're going to skip people in 50 to 250 person villages when you're a nonprofit doing your budgeting every year, because you're going to say, well, I serve 54,000 people at a cost of that someone else could serve 250,000 people. But it's not about that. It's about where as well. It should be cost per capita over kilometer squared, right? To get extremely nerdy in this talk. But I think it comes from you guys, social impact academies that pose those questions not only to your partners but your peers. And frankly, it's the ones that work with community-based groups that have the greatest onus to pull that forward. And I think that's great, and we'd be happy to be thought partners in that effort.
Great.
Yeah.
Already participated with us, so. Awesome. Thank you very much.
Yeah, thank you.
Thank you so much. And it's time to wrap up, unfortunately. But thank you, Alicia and Raj, so much for coming today and sharing what Last Mile Health is doing and the amazing impact you're making. Thank you for being a partner of Global Giving, of course. And thank you everyone who joined us online or on the Google Hangout. So yeah, if you want to stick around for a second, we'll be here. But
Great.
Yeah.
Thank
Thank
you.
you, everyone.
Thank you. When are y'all coming to Liberia?
You're driving through.
Hey,
That's a flight, right?
How you doing? How are you? Good.